Today our lecture is on calcium and phosphorus disturbances, and it will be taken by Professor Subhash Yadav, Professor Endocrinology. Sir will talk about the common disturbances in the sick patients or in the ICU settings. So post this lecture, we will be having the session of assessment. The assessment will be online, and a Google document link will be provided in the chat box. You all have to copy that Google link, and it has to be opened through your email ID, and you have to do it online only. You will be given around 30 minutes time, and then submit it online. If you exceed the time of submission, the submission may become invalid. So you have to submit in time. You will be given enough time, don't worry. So shall we start, sir? 35 attendees are there.
Yeah, we can start. Yeah, thank you. Thank you, sir.
Okay, so over to you.
Yeah.
Over to you.
So today I'm going to talk regarding the calcium and phosphorus disturbances. I will cover mainly what happened in the sick patient or in patient who are admitted in the ICU. Just a minute. Yeah. So in calcium disturbances, I will talk regarding the hypocalcemia and hypercalcemia. Hypocalcemia is the most common, and in phosphate or phosphorus disturbances, I will talk on the hypophosphatemia, which is more common than hyperphosphatemia. So uh, we know that the electrolyte disorder frequently develop in critically ill patient during the course of stay in the ICU. So the ICU patients are routinely monitored for electrolyte disorder, and it is common practice to correct them, which include calcium and phosphorus, apart from the other like hypocalcemia, hypomagnesemia. So calcium salt in won't provide a structural integrity of the skeleton, and the calcium ion. These are the basic things. This I will cover before the main topics. Calcium ion in the extracellular and the cellular fluid is essential to the normal function of the host of biochemical process, like it involved in neuromuscular excitability, blood coagulation, hormonal secretion, enzymatic regulation, cell division, and membrane stability. And the important role that calcium plays in so many processes dictate that its concentration both extracellularly and intercellularly, and it is maintained within a very narrow range. And the control of cellular calcium homeostasis is carefully maintained at extracellular. Uh, and it is mainly stored in the mitochondria and endoplasmic reticulum. And this is achieved by innervate system of control. And this homeostasis is mainly controlled by the PTH, that is parathyroid hormone, 125 dihydroxyvitamin D3, and calcitonin. So these are very basic physiology. So I will just go through it. And there are three definable fractions of calcium in the serum. Ionized calcium is 50%, that is half, and 40% is protein-bound calcium, which 90% is bound to albumin, and the remaining is bound to globulin. And the 10% calcium is bound to citrate and the phosphate. So this is normally what is the calcium concentration. Suppose there is calcium concentration, suppose there is 10. We use here in SGPGI the milligram per DL for the total calcium, and ionized calcium, which is done in our lab, we are using millimole per liter. So suppose the total calcium is 10, the protein bound will be approximately 4.8, and the complex is 0.10, and the remaining 50% is ionized calcium. So here you can see, like, from changing millimole to milligram percent, you simply multiply by 4, or other way, suppose it is in milligram per dm, divided by 4, you get in millimole per dm. And the important thing, this only free or ionized calcium is biologically active. So just a minute. There is a like important thing. There is a like when you collecting the calcium, you should aware of some error can happen. It can happen in vivo or in vitro. The most important is the use of tourniquet and the venous occlusion. If you are using tourniquet for more than 1 minute, then probably you will get increased total calcium. Even the change in posture, exercise, hyperventilation, they can change the total calcium. Even like, because of some reason there is an alteration in the protein binding or complex formation, the calcium estimation will be changed. And in vitro, if it is the inappropriate anticoagulation, dilution with the liquidity or contamination with the calcium, so these can change the in vitro calcium measurement. So we have to aware of all these things by interpreting the total calcium or even the average calcium value. Okay. So what we are exactly measuring is the total calcium, which is ionized calcium plus protein bound plus anion bound. It is usually normally in our lab it is 8.5 to 10.8 milligram percent. And but when there is a albumin is low, protein bound calcium will be also low. But the ionized calcium will be unchanged. So the corrected calcium, what the total calcium would be if the patient has a normal albumin. So if the albumin is low, then we have to treat the calcium with the following formula. That is a 4, it's taken as 4 gram per dl minus the plasma albumin what the patient is having into 0.8 plus serum calcium of the patient. So this is a very standardized formula derived to derive the corrected calcium. And such correction provide only a rough approximate of the actual free calcium concentration. However, and maybe misleading, particularly during the acute illnesses. Like acidosis can alter the ionized calcium by reducing its association with the protein. So this corrected calcium will approximately give the rough idea what is the total calcium in the body in setting of the acute illness. And ionized calcium, the normal value in our lab is 1.1 millimole per liter to 1.3 millimole per liter. Usually we use this unit. And in milligram, it will be like 4.5 to 5.5 milligram percent. And it is done by the iron specific electrode. And this is a fraction that is under the homeostasis control. And so most accurate impression whether somebody is hypo or hypercalcemic, we should do the ionized calcium. And since the ionized calcium is not yet available very commonly in most of the lab or in most of the hospital, so this is not very popular or only we are using the total calcium. So now we come to the hypocalcemia in the ICU setting. So acute rather the chronic hypocalcemia is seen only in the critically ill patient, and hypocalcemia has been associated with increased mortality in the critical. However, this relationship is mainly derived from maybe from the small single center studies, and they are not very well randomized studies. Maybe from the unitary analysis. So independent relationship between the activity of the ionized calcium and the outcomes understood. And when you read the literature, you will get a different perspective regarding the relationship of the low calcium and the mortality or duration of the stay in the ICU. So we can say half of the patient in intensive care settings are reported to have a calcium less than 8.5 milligram percent. That is on the lower side. But when you do the ionized calcium, most of these patients do not have a low ionized calcium. Patient with the severe sepsis may have a decrease in the ionized calcium. That is a true hypocalcemia. But in other severely ill individuals, the hypoemia is the primary cause of reduced total calcium concentration. So despite there is a limitation of data, the correction of hypocalcemia with the exogenous calcium had been advocated to prevent the neurological and cardiovascular complication. So what are the causes for hypocalcemia? So despite the emergences of new data regarding the hypocalcemia over the past 2 decades, the etiology in critically ill patient is an angina and likely the multifactorial. And like recent data indicate that the hypocalcemia observed during the critical illness is probably related to the cytokine-mediated inflammatory response, and it is not per se really due to alteration in the bone resorption or the increased limbic calcium excretion. But uh, other data indicate hypocalcemia during critical illness may be due to increased protein binding to albumin, relatively parathyroid hormone deficiency. There is a decreased renal hydroxylase activity, so there is a less of 125 dihydroxyvitamin. So other causes are also increased fecal or urine excretion of calcium in presence of a fixed dietary calcium intake. These are some important mechanisms like catecholamine mediated translocation of plasma calcium into the tissues. Other in the isostate was the reduced dietary calcium and often associated with the vitamin D deficiency. Like we must be knowing in our community around 85% to 90% of the people are suffering from the vitamin D insufficiency or even much more common is the vitamin deficiency. Other most important cause is the in the ICU setting when the patient is staying for the long term or they are malnourished hypomagnesemia. This is an important factor contributing to the true hypocalcemia. Other is renal insufficiency. Alkalosis is another important factor. It increases the calcium binding to the protein and there is a decrease in the free ionized calcium. Acute pancreatitis is another important factor which can cause the hypocalcemia. And other important is the when we are giving the IV bicarbonate in patient with the acidosis, and this IV bicarbonate causes alkalosis, and there is an increased binding of calcium to the albumin, and so there will be no free calcium. Some other atherogenic causes are like massive blood transfusion, fluid resuscitation, acute rhabdomyolysis. Some cytotoxic drugs are also responsible, and few medication like protamine, heparin, and glucagon may cause transient hypocalcemia. And many times these massive blood transfusion or these because of some medication, usually they don't require treatment. They are present for a few hours and they become all right after some time. So the threshold for development of the symptoms of the hypocalcemia is symptoms of hypocalcemia depend upon the what is the pH of the blood pH of the patient, the severity of the concomitant associated hypomagnesemia, hypokalemia, hyponatremia, and whether they are having any administered sedative. So common symptoms are we all knowing neuromuscular irritability, paresthesia, laryngospasm, tetany, seizure, arrhythmia, hypotension, prolonged QTC interval. And on clinical examination, you get Jostick and Townsend sign. So what is Townsend sign? Just in one side, that when you tap the skin over the facial nerve in the front of external auditory mediators, it causes the ipsilateral contraction of the facial muscle. So this is one of the roughly we judge whether the patient is having really hypocalcemia or not. But in 10% of the population, this test can be positive. Another is Townsend sign. This is regarding when you inflate the BP cuff on the arm, 20 millimeter of mercury more than the systolic BP for around 3 to 5 minutes, and you can watch for the carpal spasm. But these tests are not very sensitive, but these are the bedside simple tests. So, what are the differential diagnosis of hypocalcemia? So, care must be taken to ensure that true hypocalcemia is present or not. In addition, the acute transient hypocalcemia can be manifestation of variety of the severe and acute illness. So we have to take consider whether really it is a true, and if it is true, then it is whether it is a it's a transient, whether it's really required or not. Chronic hypocalcemia, however, can usually be ascribed to fluid disorder, and it is usually associated with the absent or ineffective PTH. Important clinical criteria include the duration of the illness, sign and symptoms of associated disorder, and presence of features that suggest the heredity or not. Other important thing is that nutritional history can be helpful in recognizing the low intake of vitamin D and calcium in elderly. And the history of excessive alcohol intake may suggest the magnesium deficiency, and which causes the action of the resistance to the PTH hormone, or even there is a decrease of secretion of the PTH hormone because of the magnesium deficiency. So there are some important investigation we should do to demonstrate there is a hypocalcemia. As I said, the important is ionized calcium, total calcium, the formula I told you, the corrected albumin to confirm the hypocalcemia. We always do the phosphorus. The low level suggests abnormality of the vitamin D, and high level suggests probably associated with the hypoparathyroidism, maybe because of the PTH deficiency or resistance. Always do the magnesium. This is very important in the critical care setting. And if it is low, before correcting the calcium, you should always replace the magnesium deficiency. Always do the 25 hydroxy vitamin D to assess the body store of the vitamin D hormones. And the low level reflect the inadequate nutritional intake of the sun exposure. And of course, intact PTH. Low level suggests PTH deficiency. High level suggests PTH resistance or inappropriate response to low vitamin D. If possible, though this assay is not very usually available, the 125 dihydroxy vitamin D. So it is for to assess the conversion of like 25 hydroxy vitamin D to the active form of vitamin D, that is a 125 hydroxy vitamin D, and it is found low in the renal insufficiency. So what is the clinical relevance of hypocalcemia? Like hypocalcemia should not be treated unless the patient is either symptomatic or they have a serum ionized calcium concentration less than 0.8 millimole per liter. So, like here it is, we are talking of millimole, it means the ionized calcium. So, if it is less than 0.8 millimole, then only you should treat, or the patient is symptomatic. Some places it is taken as 1 millimole per liter also. Taken together, study indicate the moderate to severe hypocalcemia, that is less than 1 millimole, may lead to impairment in the cardiovascular contractility, arterial contractility, and the other cardiac electrophysiology. Because of this evidence-based finding, it is current practice to keep the ionized calcium concentration at least above 1 millimole per liter, and preferably in the range of 1.1 to 1.3 millimole per liter with the supplemental calcium therapy necessary. So minimally we have to maintain ionized calcium above 1 millimole per liter. So in the management, the first step toward the treatment of hypocalcemia is to identify the potential etiology and address their appropriate management. This is the most important. The hypocalcemia after repeated transfusion of saturated blood usually resolve quickly. So if the transfusion is given more rapidly, like if it is like usually it is said that if somebody receive more than 5 units of blood, then usually it develop, and if it is given rapidly, if it is given slowly, the chances of recurring the hypocalcemia is less because the citrate is very fast metabolized by the liver. Or if the patient is having some liver dysfunction and receiving the large amount of the blood, there is a chances of developing hypocalcemia. Even some medication like propamine, heparin, glucagon, all these is causing transient hypocalcemia, and usually these transient hypocalcemia don't require any treatment. Occasionally, a low total calcium or low ionized calcium concentration are detected in elderly patient without any obvious cause and with the paucity of the symptoms, and pathogenesis is unclear. So we have to be very careful, interpreting the result in such patient. After the etiology of the hypocalcemia has been addressed, our next step is to consider the severity of the hypocalcemia and if the patient is symptomatic. So mild hypocalcemia, it is defined as when the calcium is total calcium in between 7.5 to 8.5 milligram percent, and it is usually treated with the oral calcium supplement. And next, if there is a vitamin D deficiency is the cause, you can supplement with the vitamin D apart from the giving the oral calcium supplement. If it is related to hypomagnesemia, then you stop any drug which causing the hypomagnesemia, and depending upon the level of the magnesium, you can treat with the oral magnesium supplement or IV magnesium supplement. So calcium will get corrected. Treatment of the severe hypocalcemia. So the main aim of acute management of hypocalcemia is to improve the acute clinical features, and IV calcium should be given with the close monitoring, should be on the cardiac monitor, and the calcium gluconate is preferred from the intravenous uh, form of intravenous calcium because of calcium chloride is more likely to cause a local irritation. So how we treat this patient? So 1 or 2 10 ml ampoule of 10% calcium gluconate should be diluted in 50 to 100 ml of 5% dextrose, and it should be infused slowly over 10 minutes. So this is for the treatment for the severe hypocalcemia whose patients are symptomatic. And this IV calcium gluconate can be repeated until the symptoms have cleared. And often this offer only temporary relief, and most of the time after this bolus IV calcium gluconate, continuous administration of dilute solution of calcium may be needed to prevent the incidence of hypocalcemia. So how to prepare this IV infusion? So usually 10 ml ampoule of 10% gluconate in 1 liter of 5% dextrose or normal saline is given as the initial infusion rate of 50 ml per hour. This 50 ml per hour is roughly given the 1 milligram per kg per hour calcium to the patient. So suppose 1 liter is not available, then you add 5 ampule in 500 ml of dextrose or normal saline, and you can keep the rate 50 ml per hour. With an aim is to maintain the serum calcium at the lower end of the reference range. So most of the time the requirement of infusion is like 1 to 2 milligram per kg per hour, and once the calcium become normal, then you can maintain this IV infusion around 0.5 milligram per kg per hour. And once the patient is stabilized, you are maintaining the lower level of the calcium, you can switch over to the oral calcium supplement. Now, what are the risks of IV calcium when we give by bolus? So there are chances of tissue necrosis or calcification if there is extravasation. Calcium can inhibit the sinus node, so there can be bradycardia or and develop arrest also. Stop the infusion if the bradycardia develop. Uh, when the patient is having acidosis and having the low calcium. So important thing is before the correcting the acidosis, always give the calcium, or if you are not following, then calcium can fall further when you are correcting without correcting acidosis without correcting the calcium uh, calcium level. So there are some indication for the IV calcium administration for the acute hypocalcemia. Like patient is symptomatic, patient having clinically relevant hypocalcemia, that is less than 7.5 milligram percent, patient having massive blood transfusion, and especially patient having existing cardiac disease, patient is on calcium channel blockage, overdose, patient receiving inotropes, vasopressor support, or having the coagulopathy. So these are some indications for giving the calcium administration for acute hypocalcemia. So in the long-term follow-up, when the patient is stabilized, you switch over to this calcium supplementation and add uh, 1 alpha calcidol or calcitriol. This is the active vitamin D, and monitoring with the monitoring of the serum calcium, you adjust the doses. Initially, you have to monitor once a week post discharge. Then, if satisfactory, you can increase the duration of monitoring to 1, 3, or every 6 months. So just to conclude regarding the hypocalcemia, the assessment and treatment for hypocalcemia in critical patient is complex and challenging. The clinician must evaluate the significance and the cost of the hypocalcemia and address those etiology if possible, and plan an appropriate treatment regimen and provide the appropriate reassessment monitoring. So now we move to the next problem in ICU. So this is not very common, but we do encounter in critical inpatient the hypercalcemia. So, hypercalcemia can be developed because of there must be some abnormality in peripheral function, some cause which causing the bone resorption. There must be the increased renal calcium reabsorption, or there is a dihydroxylation of vitamin D. So the important thing is like primary hyperparathyroidism and malignancy account for more than 90% of the hypercalcemic cases, mainly in the hospital setting. And some importance are like primary hyperparathyroidism and malignancy. Malignancy maybe some like humoral malignancy, which is mediated by the PTH, RP, or even solid tumor malignancy or malignancy, which is because of like local osteolysis, it is mediated by the cytokine like multiple myeloma or breast cancer. Even some drug can cause hypercalcemia. For example, thiazide diuretics or lithium. Then there can be like artifactual hypercalcemia also. This you have to take account mainly in the ICU setting when you are dealing with the acute cases of hypercalcemia, like hyperproteinemia. Because of some reason there is a hyperproteinemia, maybe because of dehydration, can cause hypercalcemia. When there is a venous statistics, like when you apply the tourniquet for more than 1 minute for the collection of the blood, that also lead to the increase in the calcium level. Hyperalbuminemia, maybe because of hyperalimentation, or hypergammaglobulinemia because of multiple myeloma. So these are the few causes which can lead to the artifactual causes of the hypercalcemia. So what are the clinical manifestation of hypercalcemia? So usually this causes fatigue, depression, mental confusion, anorexia, nausea. There is a increased urination, short QT interval on the ECG, and if it is very high and not taken care, it can cause the cardiac arrhythmia. And there is a variable relation from one patient to next between the severity of the hypercalcemia and the symptoms. Generally, the symptoms are more common if the calcium level is more than 12 mg/cent. So, in our biochemistry, as I told, like ionized calcium unit is millimole per liter, but the total calcium, the unit usually we here used is a milligram dl or milligram/cent. So when the serum calcium more than 12, the symptoms are more common. When the calcium is more than 13, there can be a calcification in the kidney, skin, vessel, various places. And severe hypercalcemia, it is defined as when the calcium is more than 15, and it is a medical emergency. If not treated promptly, it can lead to coma and cardiac arrest. So like the important thing in like diagnosis of hypercalcemia is just see whether it is not artifactual, and you reassess, reconfirm with the ionized calcium. Then you do the PTH, if possible. PTH related protein can be done, though it is not easily available. So from the PTH, you are able to know whether it is a PTH dependent or PTH independent. Then you can classify easily. Usually the PTH dependent or from the primary hyperparathyroidism, and PTH independent mainly because of malignancy or some granulomatous disease, even the Milk-Complete syndrome, or because of medication, or some patient taking it is a more common like vitamin D. Now you must have seen this sachet or this capsule gems are coming 60,000 unit, and patient, mainly the patient taking very frequently. This is one of the important causes for the hypercalcemia. So this I said, like there may be spectrum, normal calcemia, mild hypercalcemia, like up to 12, moderate hypercalcemia, and hypercalcemic crisis usually develop after 14 milligram percent. So how like whether to treat or not, if the calcium is more than 14 milligram percent, immediate treatment is indicated whether the patient is symptomatic or not. But before taking the decision, just look for the serum albumin or serum protein levels also. If there is a moderate hypercalcemia, that is a calcium level between 12 to 14 milligram percent, treatment should be based on the serum. I mean, apart from the based on this calcium level, we also look for the symptoms also. And if there is a mild hypercalcemia, that is the serum calcium from 10.8 to 12 milligram percent, we should not treat very aggressively these patients. So basic goal for therapy is the correct the dehydration. Usually these patients with high calcium, they become dehydrated. So correct the dehydration, enhance the renal excretion of the calcium, then inhibit the accelerated bone resorption, which causes the hypercalcemia, and treat the underlying disorder of hypercalcemia. So for mild hypercalcemia, I said, you can consider not doing anything, just stop the calcium replacement, stop the thiazide, and advise the rehydration for the patient. You can add loop diuretics if the patient is well hydrated. This is for the mild hypercalcemia, that is a calcium level less than 12 milligram percent. But for the patient with severe hypercalcemia, it requires a combination of approach, like some rapid acting approach like rehydration, forced diuresis, and calcitonin, and some approach in which act like after 2 to 4 days, like anti-resorptive agent, bisphosphonate, or glucocorticoid, or dialysis, or many times Denosumab. So if you use the combination of these approaches, this can bring out the calcium by 3 to 12 milligram percent in 24 hours, 24 to 48 hours. So this one slide regarding the volume expansion. Individuals with the crisis are usually hypovolemic and sodium depleted. It is result from the natriuresis and increased urine output induced by the hypercalcemia. So, like when infusing with the saline, you have to consider for like what is the severity of the hypercalcemia, what is the age of the patient, and present comorbidity, particularly whether the patient is having underlying cardiac or the renal disease, and the reasonable regime in absence of any edema, the administration of isotonic saline with the initial rate of 200 to 300 ml per hour, and then adjust according to the urine output. And mainly we keep the infusion rate around 100 to 150 ml per hour. So a practical approach consists of 3 to 4 liters of saline infused for 24 hours, followed by 2 to 3 liters per 24 hours thereafter, until the adequate urine output is established. So saline therapy requires careful monitoring since it can lead to fluid overload in the patient who cannot excrete the administered salt because of impaired renal function, which can be induced by the hypercalcemia or heart failure. So saline infusion should be stopped in patients who develop edema, and a loop diuretic may be used as necessary. Loop diuretics are not very effective in promoting the significant renal calcium excretion, and they provoke the volume depletion when used in patients whose volume deficit has not been reversed and were not fully rehydrated. So important thing, like we should not give any low diuretics unless the patient is fully hydrated. And if we give, then it may causes increasing the calcium level rather than decreasing the calcium. So generally 1.6 to 2.4 milligram percent reduction in the serum calcium may be expected with the saline infusion. Other thing which can do to reduce the you can reduce in short duration that calcium level in the calcitonin. So the pharmacological dose of calcitonin reduces the serum calcium concentration by increasing the renal calcium excretion and more importantly by decreasing the bone resorption or interface with the osteoclast function. And the salmon calcitonin usually administered initially you can start with 4 IU per kg. So roughly we suppose 50 kg person is there, so you can start with 200 IU every 12 hourly, and those can be increased to 6 to 8 IU per kg every 6 hours. Nasal application is available, but it is not very effective in treating the hypercalcemia. This is more is good for the treating the osteoporosis. Advantage of subcutaneous calcitonin is it works rapidly. We lower the serum calcium concentration by a maximum of 1 to 2 milligram percent within 4 to 6 hours. And the efficacy of calcitonin is limited to the first 48 hours, even with the repeated dosing, mainly because it develops tachyphylaxis. So this is a major disadvantage. Like after 48 hours, most of these calcitonin doesn't work because it develops tachyphylaxis. Other important agent is the bisphosphonate, which is given for treatment of hypercalcemia. It is quite potent than calcitonin and saline to treat for treating the patient with moderate or severe hypercalcemia. So as a result, they have become the preferred agent for management of the hypercalcemia due to excessive bone resorption for a variety of causes, mainly malignancy-induced hypercalcemia. So they work by blocking the osteoclast mediated by the bone resorption, via promotion of osteoporosis, apoptosis. So oral bisphosphonate bioavailability is limited, and nausea, anorexia, and vomiting are frequent concern in patients with severe hypercalcemia. So because of this, intravenous bisphosphonate are preferred, and their maximum effect occur in 2 to 4 days of after giving the injection. Zonotonic acid is highly active and potent intravenous bisphosphonate approved for the treatment of hypercalcemia malignancy. The dose for zonotonic acid is 4 milligram, and like the patient having complete response in half of the patient develop complete response in 4 days, and around 83% in next 7 days. If required, it can be repeated after 1 month. Another agent nowadays not very commonly used in adult patient is a pamidone. This is quite old drug. It was we used to use this drug before this zonotonic acid came, and it is given in the dose of 90 milligram, and it can be repeated after 3 weeks if required. So if there is somebody is having reduced clearance, that is between 30 to 60 ml per minute, dose of zonotonic acid should be reduced, but there is no changes in the dose of pamidonic acid. In patient with creatine clearance less than 30, zonotonic should not be given, but pamidonic infusion can be extended to 4 to 6 hours along with considering giving the dose reduction. Ideally, serum creatine levels should be obtained before each dose, and next dose should be withheld in patient with significant increase from the baseline. So, combination of calcitonin and bisphosphonate in addition to rehydration with forced dialysis may therefore be the most valuable in acutely ill patient where rapid calcium lowering is warranted. Glucocorticoid is another option available, but this is mainly limited to the patient having hypercalcemia because of hematological malignancy like lymphoma, multiple myeloma, or hypercalcemia because of granulomatous disease, or patient develop hypercalcemia because of vitamin D intoxication. So such patient glucocorticoid will be usually reduce the serum calcium within 2 to 5 doses, and in such patient prednisone is given in the dose of 20 to 40 milligram per day, and over like 1 to 2 weeks, depending upon the response, is when can be tapered and stopped. Another option is dialysis, and that is the hemodialysis with little or no calcium in dialysis fluid, and peritoneal dialysis are both effective therapy for the hypercalcemia. And it is indicated in the patient having the severe malignancy associated hypercalcemia, renal insufficiency, or the heart failure. It is used mainly when the serum calcium is very high, in the tune of 18 to 20 milligram percent, and when the hydration is not very safe, and so it is used as a last resort. There is no specific evidence-based data to guide the clinician to which the individual are more likely to benefit. So this is a newly drug which is nowadays used with the hypercalcemia when you cannot patient cannot even the bisphosphonate therapy. It is a human monoclonal antibody that binds to rank ligand and inhibit the maturation, activation, and the function of the osteoclast. This is an option for the patient with the hypercalcemia that is refractory to zolidinic acid or whom the bisphosphonate are contraindicated due to severe impairment. And there are increasing number of the case report and case series of this Denosumab for the management of hypercalcemia of malignancy, particularly in the patient with the persistent hypercalcemia despite bisphosphonate. So, there is some case series in which they have given the Denosumab 120 milligram every weekly for 4 weeks, then monthly thereafter they continue. So what they have seen, like after 10 days, like more than 50% of the patient calcium level has become normalized, that is less than 10.8 milligram per cent. So this is another agent used for the to treat the hypercalcemia, but that is a calcimimetic drugs, and this is mainly used in the parathyroid carcinoma because they reduce the PTH synthesis and secretion and lower the serum calcium level. It causes dramatic reduction in the serum calcium level. Patients who are taking the this calcimimetic drug, most commonly available is sinacalcet. Surgical treatment, this is mainly for the patient who are having the primary hyperparathyroidism and the PTH is high. So, and when the calciums are very high, so what it is said that you should not go for the very urgent surgery. First stabilize with the medical treatment. When the patient is stabilized the medical treatment, then you can go for surgery as early as possible. So just in short, management of severe hypercalcemia, important thing is the immediate is the hydration with the saline, and when the patient is hydrated, you can think of giving the forced dialysis and the calcitonin also. And other drug you can give to the patient who are in hypercalcemia apart from the saline, forced dialysis, and calcitonin is the zolidinic acid, though effects will come after 2 to 4 days. Patients who are having the malignancy or having the hypercalcemia because of granulomatous diseases, they can be given safely the glucocorticoid. And the patient having very severe hypercalcemia, mainly because it occurs because of malignancy, like 18 to 20 milligram per cent. So you can advise them for the hemodialysis. So now just few slides regarding the hypophosphatemia and what is the clinical effect and management. So So it is a more like frequently encounter electrolyte disorder in critically ill patient. In some like here you can see in some series like even 100% of the patient having this hypophosphatemia. So it is quite common in the ICU, whether it's medical ICU, surgical ICU, or patient having gone. So we know that it is an essential element for all the living cells with different functions, like it helps in bone structure, structure of the cell membrane, energy storage, and metabolism. Acid base is act as a acid base buffer. Uh, in the cell and the extracellular fluid, phosphorus exists in several forms, predominantly in the dihydrogen phosphate, sodium hydrogen phosphate, and hydrogen phosphate. This mixture of anion will be referred to as a phosphate. So normal concentration is 2.5 to 4.5 milligram percent. In our chemistry lab, the unit is milligram percent, and 87% is diffusible, 35% complex to different ion, and 52% is ionized. And here we measure the serum phosphate. 30% is in non-diffusible protein bound state. 85 to 90% is found in the bone, and the rest in ATP, cyclic AMP, and the protein. And phosphate balance is quite complex. Is interplay between like phosphate uptake and the phosphate excretion. And the causes for the hypophosphatemia is concerned is can be because of depletion of the total body phosphorus store, or many times in the ISO setup there is a redistribution of phosphates to the from extracellular to intracellular. And other important cause is the decreased intestinal absorption of the phosphate. So these are the three important causes for the hypophosphatemia. So redistribution across the cell membrane is the most common cause of the hypophosphatemia in the ISO setting. So important things are like respiratory alkalosis induced increase in the intercellular pH causes the phosphate to enter the cell by stimulating the glycolysis. Other important cause for the redistribution is the glucose and the insulin administration. It stimulates the carbohydrate metabolism, during which the phosphate is transferred into the cell along with glucose. Another important thing is the high level of catecholamines such as epinephrine, norepinephrine, whether it is a exogenous or endogenous, causes the decrease in the serum phosphate level. Cellular uptake of the phosphate is increased under the certain specific conditions such as hungry bone syndrome and disease with rapid such as acute leukemia. Renal excretion of phosphate is increased by the metabolic acidosis, and many drugs like dialysis, glucocorticoids. I mean, these are commonly used drugs in the ICU setting. Aminoglycoside now it is less commonly used. Antiretroviral drug, anti-cancer drugs. So all this causes the increase in the phosphate excretion through the kidney. Serum phosphate level are inversely correlated to level of the inflammatory cytokine, interleukin 6, and tumor necrosis factor alpha. Hypophosphatemia can be found in patients with severe infections such as sepsis, especially with the gram-negative bacteremia. Hypophosphatemia also develop in post-operative phases, and the multiple factors are there like respiratory alkalosis, this we have seen, and administration of insulin and use of diabetes. After the major hepatic surgery, hypophosphatemia is extremely frequent, and it is mainly because of shift of the phosphate into the hepatocytes, and also there is a renal phosphate wasting. Similarly, the hypophosphatemia is reported in the trauma patients. In patients with the malnutrition, the refeeding syndrome may develop and they receive the parenteral feeding, which is characterized by the multiple metabolic abnormality, including the depletion of total phosphorus store and redistribution of phosphate to the intracellular compartment. Hypothermia, it induces the polyuresis and associated with the hypophosphatemia. Use of renal replacement therapy is also associated with the low phosphorus level. Patient with diabetic ketoacidosis, it is also related to the low phosphorus level. So, regarding the clinical and laboratory finding, hypophosphatemia is usually characterized as a moderate or severe. Moderate is like when it is 1 to 2 milligram percent, and severe when it is less than 1 milligram percent. So, serum phosphate level do not accurately reflect the total body phosphorus stored. Hence, the degree of hypophosphatemia does not always correlate with the presence of the symptoms. Although the most patients with hypophosphatemia do not develop symptoms, though fatal complication has been described. Clinical manifestation of severe hypophosphatemia reflect a generalized defect in the cellular energy metabolism because of ATP depletion and a shift from oxidative phosphorylation toward the glycolysis and associated tissue or organ dysfunction. So acute severe hypophosphatemia occur mainly or exclusively in the hospitalized patient with underlying serious medical or surgical illness in pre-existing phosphate depletion due to excessive urine losses or severe malabsorption or malnutrition. Neuromuscular manifestation of severe hypophosphatemia are variable, but it includes like muscle weakness, lethargy. But it is very difficult to just differentiate from clinical feature whether it is related to general condition or the hypophosphatemia. Serious sequelae such as paralysis, confusion, and seizure are likely only at the phosphate concentration less than 0.8 milligram per day. And rhabdomyolysis may develop during rapid progressive hypophosphatemia. So this is a very serious complication of hypophosphatemia. Similarly, the respiratory failure and cardiac dysfunction, this development is reversible with the phosphate treatment. They can have a like a renal tubular defect, and they can have a hematological abnormality, which include erythrocyte microspherocytosis and hemolysis, impaired oxyhemoglobin dissociation, and they can have a defective leukocyte hemostasis, phagocytosis. Multiple studies have shown association between hypophosphatemia and increased mortality. Severe hypophosphatemia has been reported to predict the 8-fold increased mortality rise in the septic patient. However, hypophosphatemia does not associate with increased mortality after cardiac surgery and in diabetic ketoacidosis. So, because of this conflicting report, it is remain unclear whether hypophosphatemia is actually contribute to the mortality or may a marker for severity of the disease. And the correction of hypophosphatemia reduced mortality is currently unknown. And it is generally recommended to correct the hypophosphatemia in hypophosphatemic patient with associated symptoms only. And there is no randomized controlled trial evidence indicate whether the correction of hypophosphatemia is apparently asymptomatic lead to improvement in outcome. So the correction of hypophosphatemia is possible via the oral and the intravenous route. Intravenous administration of phosphate is not without complication. So we have to be very careful taking the decision while treating the hypophosphatemia with the IV phosphate. Because this phosphate may precipitate with the calcium, and large intravenous doses of phosphate may result in hypophosphatemia, hypomagnesemia, hypocalcemia, and hypotension. So intravenous therapy is generally recommended in symptomatic hypophosphatemia and when the phosphate level are less than 1 milligram per cent. Otherwise, most of the time it is treated with the oral phosphate only. So normally, if some patient is taking normal diet, this normal diet contains around 1000 milligram, that is 1 gram of the phosphorus, and there are various other preparations are available, most commonly like Adphos tablet P250. It contains 250 milligram of the phosphorus. Other is Adphos sachet. It contains the 500 milligram of phosphorus. There are this preparation like Na2HPO4 and NaH2PO4. Suppose you mix in particular combination like 3.6 gram of Na2HPO4 and 1 gram of NaH2PO4. So this will give around 1 gram of the phosphorus. There are other preparations are also available. The injections available in two forms: potassium phosphate injection or sodium phosphate injection. So moderate hypophosphatemia can be treated with the oral supplementation of the phosphate, but should keep in the mind that active vitamin D is required for the intestinal absorption of the phosphate. Typically, oral supplementation amounts are 2 to 3 times the normal daily intake, with advised amount of 1.5 to 2.5 grams per day in divided doses. Intravenous phosphorus treatment for hypophosphatemia, as I said, it is generally indicated when the phosphorus level is less than 1.0, that is milligram percent, and the rate of infusion in millimole per hour is like 8 millimole per hour. It should be given duration of 6 hours, and it should be you should repeat the serum phosphorus. If it is like going more than 2.5, then you should stop. So in short, what I want to say here, the intravenous therapy for hypophosphatemia should be given when there is a severe underlying phosphate depletion and there is a concurrent parenteral glucose administration and presence of neuromuscular, cardiopulmonary or meteorological complication of hypophosphatemia. If the creatinine is more than 2.5 milligram percent, you reduce the uh, dose by 50%. And if there is a hypocalcemia, you should treat the hypocalcemia first and then give the reduced doses IV phosphorus. So this is from on my side. Thank you.